yes, an exchange. And I'm thinking if to start with Winnie, I have to excuse Winnie, and she herself told it that she is now being called to have a meeting with the Excellency Head of State. So Christine Sterling, our Deputy Executive Director, kindly agreed to deliver Winnie's remark on her. And then should we, I also would like to apologize for Sheila Chu, Professor Sheila Chu, which is a co-chair of the GPC. She unfortunately lost her mom 3 years ago, 3 days ago, and that for I try. I'm for the SIMAG. I'm working on UNAIDS, and I'm a director of one of the global practice covering prevention in UNAIDS. Thank you. So, Christine, over to you.
Yes, so we are all playing a double role, Honorable Minister. As Fode has said, I'm stepping in for our Executive Director, Winnie Byanyima, who has a meeting with the head of state right now. So let me just welcome you on behalf of UNAIDS, on behalf of our Executive Director. Honorable Minister, we're delighted that you are joining us. Let me also thank you for your hospitality and for welcoming us to your country. Distinguished guests here on the panel, Peter, Yogen, friends from civil society, and colleagues. Allow me to just make a few remarks about why we're here. This is a conversation about leadership in HIV prevention, and we are all very aware, everybody who is sitting in this room and who is joining us from elsewhere, that we are off track where prevention is concerned. We still had 1.3 million new infections in 2022, and almost half of those new infections were on this continent in Africa. So our goal for 2025 is that we will reach fewer than 370,000 new infections per year. And we know we need to do things differently if we're going to reach that goal. We know that HIV treatment has been incredibly powerful to reach, to save life, but also to reach some of our targets. But we do know that this alone will not, what we call, turn off the tap of new infections in any of the countries we work in. Unfortunately, I think for many years we have talked about this. There is no silver bullet for HIV prevention. It asks of us to do a combination of different things, including biomedical interventions, including creating an enabling environment, including working with communities. But we have a huge opportunity at this particular moment. Because we know what to do and we have the tools, and in many countries we have the political will and also the financial resources to do the right things. However, we do know that the tools and technologies that we have are often not made available widely enough. They're not scaled up. We have the same inequalities that keep people away from condoms, that keep people away from other prevention technologies, are also keeping people away from new technologies such as PrEP and self-tests. And we know that we have populations that are left behind. And on this continent, we do need to keep on talking about the fact that 63% of new HIV infections were among women. And that we know that adolescent girls and young women, 3,100 of adolescent girls and young women are infected every week in Africa. So we have our work cut out. We do know that we have to act, and we have to act differently. We know that we have gaps in HIV testing and treatment among men, and that means these gaps have negative effects on the health not only of men, but it also means they create a continued higher risk of HIV transmission on their partners. And 3 decades into the epidemic, as we all know, we still have to close prevention and treatment gaps amongst key populations, amongst sex workers, gay men, and other men who have sex with men, transgender people, and people who use drugs, and people in prisons. At the same time, and I think it's really important to keep on pointing this out, we have good examples in Cameroon, in Lesotho, in Malawi, in Rwanda, and in the country where we currently are, in Zimbabwe. Countries that are participating in the Global HIV Prevention Coalition the number of people who newly acquired HIV declined by more than 70% between 2010 and 2022. So it shows us that progress in prevention is possible when countries and communities take the lead and all partners pull together. We now need to turn possibilities into realities. Together, we can make prevention work in all countries. The Global HIV Prevention Coalition, which was created in 2017, is our platform for sharing good examples and making them the norm. We have a 2025 prevention roadmap, which is a 10-step how-to guide map, and which gives us pathways to achieving impact and sustaining impact. If you haven't seen the roadmap, please have a look. Many of the countries that are successful in the coalition also translate this prevention roadmap in their own countries into national roadmaps. And importantly, in those roadmaps, what we have is bringing together communities, government services, and development partners, but importantly, also pointing out the need for accountability and continuous need for holding ourselves accountable for doing the right things. We know that we cannot sustain the HIV response unless we make HIV prevention work. And so we need to urgently prioritize, and we need to advocate and make bold investments in the right forms of prevention, where the ones that make the most sense in the communities where we work and in the country context where we are. We need to urgently address the underlying inequalities that pose barriers for access to services and for prevention choices. So the support of the international community, of UNAIDS, of the Global Fund, of PEPFAR, of the Gates Foundation, other development partners is critical. But we also know that to sustain the impact we are having and securing the gains that we are making, leadership by affected countries, by communities, is the only way that we'll be successful in the long run. So it's our moment here at the conference to talk about that accountability and that leadership for the HIV response in 2023, moving towards 2025 and 2030, where our overall goal, as you all know, is to end AIDS as a public health threat. So I'm looking forward to the conversation. I want to welcome you again, and I want to welcome the minister again, and I'm looking forward to hearing everybody's thoughts on this distinguished panel. Thank you.
Thank you. Thank you, Christine. Thank you for your words. So you just reiterate that we have tools, strategy, instruments, and you mentioned some of the country here who are doing amazing progress. So my first question will be to you, Dr. Douglas Mumbochera, Minister of of Health and Child Care. We just heard that the Zimbabwe has recorded a 78% reduction of new infection between 2010 and 2022. To be honest, is the steepest decline in HIV incidence among the GP, the country participating to the Global Prevention Coalition, as mentioned, Christine. So, question would be simple: what are the key factors behind the progress and the success? And do you have some remaining priority for the country on the road to 2025? Over to you.
Thank you very much for inviting me to this panel. And like the previous speaker said, we now have in this world the tools, the drugs to make sure that we deal with HIV. But I think the most important factor is the human factor. That's the factor that drives all this to be a success. Maybe I'll just talk about the Zimbabwean situation. Zimbabwe has made significant progress in the HIV and AIDS response since the first case was identified. I'll just outline some of the high-level key steps that we took to achieve that. First is that Zimbabwe declared HIV and AIDS as a state of emergency, which facilitated the following key actions. It enabled the establishment of the National AIDS Control Program at the level of the Ministry of Health and Child Care through medium-term plan, which was medium-term plan 1. This ensured that the country got to an early start to respond to the HIV epidemic through a national health sector-led response. Secondly, there was establishment of the National AIDS Council as a follow-up on strategy of medium-term Plan 2 through an act of parliament with decentralized structure from national, provincial, district, down to the ward level. This broadened the response to activate a multi-sectoral approach, augmenting the health sector response. This also led to the establishment of the National AIDS Trust Fund to harness domestic resources as well as heightened awareness of the epidemic. It also enabled mainstreaming of HIV and AIDS into all line ministries of government. And it led to the introduction of behavioral, biomedical, and structural interventions. From the 90s, early 90s, the country introduced a scaled up abstinence, that is, be faithful, consistent use of condoms, delayed sexual debut, an approach with lots of emphasis on comprehensive condom programming that embraced both public, social marketing, and private sector condom distribution. Great success was realized using this approach, and my country is one of the first with the highest per capita condom distribution in the region for both male and female condoms, with over 100 million units being distributed annually. Condom use has been sustained throughout the epidemic, and the country is currently working on the total market approach, where Parliament has been petitioned to make a deliberate decision to remove value-added tax and excise duty on all condoms. Zimbabwe has also embraced voluntary medical male circumcision, and over 2.5 million men have been circumcised, averting nearly 12,000 new infections by 2017. All these initiatives have been due to a strong government leadership with dedicated Ministry of Health and Child Care departments tasked with HIV prevention, care and treatment, as well as strong partnerships with bilateral, international, and developmental partners. Through the visionary leadership of my ministry and government, Zimbabwe has been an early adopter in other biomedical HIV prevention interventions, such as pre-exposure prophylaxis. As of December 2022, 95% of HIV positive individuals knew their status. 100% of these were on treatment, and 95% of them were virally suppressed in the general population. Technically, Zimbabwe has achieved epidemic control. However, despite this achievement, gaps still exist among key and vulnerable populations, that is, children, adolescents, and key populations. As for the key priorities, my ministry has embraced HIV prevention 10-point action plan and to reduce new infections among key and vulnerable populations through early adoption of new technologies and scaling them up. We are also planning on scaling up efforts on triple elimination of HIV, syphilis, and hepatitis B among children in Zimbabwe. We are also prioritizing a people-centered approach to the delivery of services to make choices among the expanding array of HIV prevention options. And we would also want to increase resources for HIV prevention and treatment, mobilizing all relevant sectors to take meaningful actions to reduce new HIV infections. We would like to create an enabling environment and policies to implement combination HIV prevention strategies and to support implementing differentiated and contextualized programs and interventions. We are also prioritizing strengthening the public-private partnerships in the delivery of combination HIV prevention interventions, including activation of reporting mechanisms by the private sector. And we would also want to use data to inform precision prevention. And lastly, we want to prioritize retention of human resources for health as a sustainability pillar which is central to all the initiatives mentioned above. I think these are the points that I would want to share with you. Thank you.
Thank you, Honorable Minister. So we saw that is a combination of multiple factors that come under your leadership, and we know that for to be successful in prevention, we need political leadership, we need technical leadership, we need programmatic leadership, but we need also financial leadership. So my second question will go to you, Peter. I think everybody know Peter Tan, who is the executive director of the Global Fund Fight Against HIV, tuberculosis, and malaria. And Peter, Global Fund has been part of the Global Prevention Coalition since the beginning, an active member. We also have seen, and I remember you saying that it's unfortunate that the decline on investment on prevention since 2010, but then the last 4 years we saw again a restart or reaugment, rescaling up of the money put in prevention, but there is still a gap. So, what the Global Fund priority in supporting country prevention roadmap? That how would you think the Global Fund planning to support the sort of sustainable national HIV prevention? That's the two questions. Thank you.
Thank you for the question, and it's a privilege to be on stage with such great partners in the fight against HIV/AIDS, and particularly through the Global Prevention Coalition in reducing the incidence of new infections. Uh, the Global Fund is completely committed to working with the GPC to scale up and make more effective interventions to prevent HIV infection. And indeed, one of my personal KPIs is reducing incidence of HIV. And we know that that means um, increasing access to prevention services to the people most at risk. So KPs and adolescent girls and young women in particular, and their partners. Um, you talked about money, but I actually think we have to get multiple things right to have an effective prevention strategy. We have to have the tools, we have to have the money, we have to have the access, and then we have to have delivery models that work. If I just skip through those quickly. Tools, we actually have some pretty powerful tools, but we've got to scale up some of the ones that we've had for some time but aren't using enough. Condoms, Zimbabwe's done a great job on condoms. PrEP, oral PrEP, there's huge opportunities to use oral PrEP more. But then there are newer tools such as long-acting PrEP or the long-acting opiate substitution treatments or the vaginal ring. And we need to make sure that we don't do what we've sometimes done in the past in global health, which is to take a very long time to get innovations to the people who really need them. We need to get these innovations out fast. So I see both scaling up existing tools that work and getting the new tools to the people who can both benefit from them as two key priorities. That, of course, takes money, which is always the challenge. Um, Now, I wish I was an alchemist who could turn, all sorts of substances into gold. Unfortunately, I haven't mastered that one yet. Um, but what we are seeing actually in the preparations for Grant Cycle 7, so the new grants that in most countries are beginning in January 2024, is a substantial uptick of probably around a 40% increase in how much countries are deciding to spend on prevention. And that involves really tough trade-offs because obviously what's taking up a lot of the budget is antiretroviral treatment. And there are difficult trade-offs that countries face between the pace of scaling up antiretroviral treatment and the pace at which they scale up prevention. But I'm encouraged by the fact that we're not looking at a 5% or 10%, we're looking at a 40% plus type of increase. But having the new tools and having the money is no good at all if the people who need it don't have the access. And that's why the erosion of human rights for LGBTQ plus people in many countries, both rich and poor, and the stalling of gender equality in many places is such a real concern, because we're not going to solve this problem if people are criminalized, stigmatized, discriminated against. And it's also where the role of communities in reaching out to those people and advocating for their rights is a critical part of it. And that brings me to the delivery models. This is an area where I think we have to work even harder across the partnership around thinking of creative ways of opening access, whether it's distribution through pharmacies, whether it's self-testing, whether it's integrating prevention services into broader SDI or SRHR type services, or it's using schools more effectively for AGYW. There's a range of innovations, and in fact, many of them are already happening in some places. It's just we're not doing them at big enough scale to move the dial. But I want to come back to the fundamental point about all of this, which is my fundamental concern about all of this, which is we can do a lot of great things with prevention. We have tools. There's an enormous amount of good examples from different countries. There is not enough money, but there is money. But fundamentally, people have to care. And if they don't care, it's not going to happen. Last week I was at a World AIDS Day event with Elton John. Now, Elton John, as I'm sure people know, has been this amazing champion of the fight against HIV/AIDS for a very long time. Although, interestingly, he always says he feels really guilty about the first few years of the AIDS epidemic when he sort of didn't really get it. And it took him a little time to really realize that he could use his power and influence and voice, which he has since then done incredibly effectively. He gave a very passionate speech at this event I was at. And the thing he was talking about, and I don't know how the translators will deal with this, is he talked about the concept of othering. And what he meant by othering was talking and thinking about other groups of people in ways that deny their humanity, which allows you to treat them badly or just simply neglect their need. And I think we do see this phenomenon of othering in the fight against HIV, especially in the people who most need HIV prevention. We're seeing othering in other contexts, in conflicts around the world, in the treatment of migrants and refugees, in ethnic and religious concepts. But fundamentally what it is it's the complete opposite of the global solidarity and the common humanity that drove the creation of organizations like the Global Fund. It's the really not treating other people as humans. And I think we have, and certainly in the Global Fund, we reject that notion, and we need to rediscover the energy, and we need to reinvent the sort of vigor of concepts of global solidarity and common humanity. Because if we don't get that right, we won't have the fundamental political underpinnings to drive the HIV prevention and more broadly the fight against HIV/AIDS with the energy it'll really require to hit the 2030 goals.
Thank you. Thank you, Peter. Yes, we heard that there is not enough money, but there is still money, and what is needed is more than money, and is a sort of our personal, collective sort of commitment, engagement, and work together and think differently and go beyond the biomedical approach. I'm now pleased to uh, pro- introduce Jorgen Pile. Jorgen was the South Africa department, the head of South African Department of Health, and he is now the director for Bill and Melinda Gates HIV and tuberculosis delivery. But he has huge experiences at the country level on delivering services in the largest epidemic in the world. So, Jürgen, if you go beyond South Africa, how in your view, how, how can countries in Africa, despite the limited resources, could scale up HIV prevention in a sustainable manner? What do country response leadership needs to be in order to hope to have a sustainable prevention and go beyond 2030?
Great. Thanks very much. That's a great question, only because the minister from Zimbabwe has already answered that question. He's told us how Zimbabwe, with the resources they've had, have been able to respond to the HIV epidemic, both on the treatment side, but he's emphasized the prevention side. So, if we're looking for good examples, Zimbabwe
Is
is
it good?
one of the greatest examples. So I think they deserve a really round of applause for doing what they've done. Now, that said, the work is not finished. Um, and I don't think we need to be too pessimistic as HIV activists or program managers or funders, because I think a fair amount of work has been done. And I think we do need, though, to reimagine HIV prevention. And the reason I say that is because HIV is not unique amongst the diseases and the illnesses that we are failing to prevent. If you look at the new and emerging epidemics on this continent, it's diabetes and hypertension. And we're going to have the same challenges with getting people to exercise, eat the right foods, etc., etc. Probably more difficult. So we've got to reimagine not only HIV prevention to get to the last mile, but also prevention writ large. And that relates to, I think, some of the things that both the minister and Peter said, is that we need to better understand risk, but also move from risk, because risk, I think, is part of the otherness as well. So I think we need to move from risk and focusing on only risky behaviors, the negative things, to positive things like, how can we assist people to make healthier choices? If you ask young people today, or in fact, if you ask anyone today, if they are terribly bothered about contracting HIV, the answer is probably no. They're not particularly worried about HIV. They're probably more worried about getting a job, finding access to employment, finding access to food, etc. So we've got to rethink prevention. If we are going to be focusing on prevention, especially to get to the last mile, in the way in which we've been doing it historically, I think we'll struggle. Now we know what works. The minister made very clear condoms work. We know that focusing on vertical transmission and stopping vertical transmission works. But yet we have significant transmission in the postnatal period. So that's something we should be focusing on because we're not doing well with preventing HIV in children. And I think we need to focus far more on children, and we know it can be done. We have a very good historically PMTCT program. We've got to look beyond the conception and delivery stage. We've got to look at the postnatal stage. And then, I think we've got to ensure, in order to make these new technologies sustainable and affordable, we've got to work with those folk who are producing them to reduce the prices sufficiently and to get the volumes as quickly as possible. You see, Peter is right. All of these technologies are only good if they get to people who need it, in the ways in which they can use it, and given the choices that they make about using them. I mean, if you look at Cabernet right now, there is just no product in Africa. So we have a technology. Firstly, we can't afford it, I don't think, and we don't have the volume that we need. Now, I do hope that with the additional and other products like lenacapavir, we don't fall into the same trap. So I think the onus is on some of the funders to work more closely with the manufacturers to ensure that the pathway from R&D to delivery on some of these new products is as rapid as possible, and that these products are affordable. Because if they're not, quite frankly, asking the Minister of Zimbabwe to include long-acting PrEP in their program is absolute non-starter unless it can be affordable. So, we've got to work harder at these things. And then finally, on the delivery side, I do think we need to integrate HIV prevention into other things. What comes to mind for children, for example, is to integrate it into the first 1,000 days. We've got this plan, first 1,000 days. It protects children, protects them, the caregivers as well, and it reduces under 5 mortality. It's something I think we can do and we should be doing. So I think integration into that, into the antenatal care program, into EPI, and into sexual and reproductive health and rights are key. And I think we shouldn't forget gender-based violence. I think it's a major trigger for HIV transmission and acquisition, and we certainly got to do more. And this continent in particular, we have an epidemic of gender-based violence, and it's men that are driving it. And I think we need to get men on board in many, many ways. And I think we often neglect holding men to account for their behavior. Thanks very much.
Thanks, Dr. Peter. Thanks for bringing us very concrete thinking and way forward based on your experience. So, while we are talking about experience, it's my pleasure to introduce our sort of country community implementers, which will tell us what are they facing, how they are seeing things being on the ground on a day-to-day basis. We'd like to first introduce Dr. Temezile Zulu, who is the Chief Executive Officer of the South Africa National AIDS Council. So, Timbe, how's South Africa working together achieving national and global prevention target? You are defining a roadmap. What will make the greatest difference on the next 2 years in your perspective in prevention in South Africa?
Thanks, Dr. Fode, and good afternoon, everybody. Zulu versus Kulu. My name is
Zulu.
Dr. Tembisile Kulu. I am the CEO of the South African National AIDS Council. Good afternoon to the panelists and everybody, and to the minister. So in 2023, South Africa launched the 5-year National Strategic Plan for HIV, TB, and STIs for 2023 to 2028. We are very clear that this is the last NSP that will take us to 2025 for our current targets, but also the last 5-year NSP before Agenda 2030. So failure is not an option. This NSP is very community-centered, it's rights-based, and it's human-centric, and it has been fondly dubbed by our civil society as the people's NSP. Community-led monitoring of prevention services in South Africa is something that has been alive for years through the likes of the PLHIV sector, the Treatment Action Campaign. And we've just had to do a few tweaks in country, looking at the UNAIDS CLM model, as well as guidance from Global Fund, but incorporating that because we understand the meaning of letting communities lead. We are fortunate that in South Africa, 74% of the response is still funded by the government, which speaks volumes in terms of sustainability. But 18% of that is actually put aside for prevention within the NSP. And it is the investment case for HIV that continues to guide priorities in terms of the interventions. Condoms remain the most cost-effective intervention, and those are being driven hugely from domestic funding. And we are currently distributing about 800 million condoms per annum. One of the areas that South Africa has done really well in terms of prevention is what Yogan was describing, now called the Vertical Transmission Program, previously referred to as PMTCT. About 10 years ago, we were at about 6-7% transmission. And in 2022, we are sitting at around 1% at birth. And this is one something that we need to maintain it as a country because one, we need to end AIDS in children. But if you look at the picture that we are starting to see with young women becoming infected by older males and becoming HIV infected, they also have a high rate of teenage pregnancy. Yet we are saying the very same young people are not testing enough. When we test them, they don't get on treatment. When they do start treatment, they fall off early, so their level of attrition is high. Therefore, these are the same young women that have got the potential of reintroducing babies living with HIV into the system. So we can't afford to regress and to drop the ball purely because we have done well on vertical transmission. And when you look at even the data that the Human Sciences Research Council brought out last week for South Africa, viral suppression in young girls is much lower than it is in young boys. So those are areas that we still need to focus on. I dare to say as well that the babies of key populations actually bring about the same potential risk of regression. Because if a female sex worker falls pregnant, has to have a baby, but has got difficulty getting access to treatment, then we are regressing. We are bringing more babies that are living with HIV into the system. So our focus, I think, as a country moving forward is definitely bridging that gap between research, policy, and action. We've seen too many examples where implementation sometimes overtakes policy because we are too late in terms of policy development. We certainly learned a lot of lessons from the rollout of oral PrEP in South Africa, as well as from COVID. But I also sit here as a member of the steering committee for the HIV Leadership Forum. So under the Global Prevention Coalition, the GPC member states have put together a community of practice of NAC directors, so NAC director generals. We met in Namibia in November, and we are essentially a forum that is helping countries to define the meaning of effective coordination for the HIV response, lest we regress. Because at the rate that we are going, the HIV agenda is falling off the table, even as we discuss packages for universal health coverage. And we are the ones that need to keep the HIV agenda on the table. So effective coordination of prevention efforts, as we spoke about in Namibia at country level, might include simple things like we've got multiple pilots running for the dapivirine ring, as well as for long-acting cabotegravir. And if we are saying we want to move from prevention projects to prevention systems, we need to get to scale for our prevention efforts. And it's very hard to get to scale when multiple funding sources are being directed to multiple projects or programs that are not being coordinated at a center. Just now, Jorgen was saying that even the manufacturers want volume in order to be able to produce. And if those efforts are not coordinated at a country level, it's difficult for us to secure that. Therefore, when we are in project mode, we compete, but when we are well coordinated, we actually make it much easier for a country to function. So part of what we discussed as the HIV Leadership Forum is that we have brought out policy guidance on how to steward HIV leadership at country level. And this has been endorsed by the member states of the GPC coalition, and it's going to be released and available for all. And I think we've also said that sustainability has very much been defined as aligned to just financial sustainability. We recognize that it's not just a dollar-to-dollar exchange. We need to find pathways that allow countries to identify and review and prioritize to make sure that the HIV responses that they are leveraging or implementing actually look deeper, not just into the health systems of the country, but into the social and economic systems, and that we define HIV integration in the full picture of the services that a country is supposed to deliver in the true spirit of multi-sectoralism. And this is quite timely as I go towards my closure, especially in my country, where people that started antiretroviral treatment at the very beginning, when the Elton John program started, They are now in the 50s, late 40s and 50s. I don't want to say, but they are now my age group. Those are now my age mates. And we need to be looking at health budgets that look beyond just HIV, TB. NCDs are an issue. Their mental health issues are coming into play. And we are all discussing the move towards universal health coverage. And as long as key populations remain criminalized, I think our prevention efforts will be in vain. Firstly, there will be no data for them because they will not be coming forward. We won't have the data, so they will be left behind. As long as key populations are criminalized, there will be no epidemic control. As long as key populations are criminalized, we will not end HIV as a public health threat. And as long as key populations are criminalized, there will be no universal health coverage, and that will be a disaster for our prevention efforts. Thank you.
Thank you. Thank you, Tembi. I would say Tembi, it's easier for me. You know that the problem is to be a francophone. Um, it's my pleasure now. We all say community on the lead, community at the center. So we have with us Nyasha, who is from Zimbabwe, and she's the co-founders of the Dawa Network. She's as a young leader engaged for about more than a decade on HIV prevention and women empowerment. So, Nyasha, how are you seeing today the contribution of the youth leaders in prevention right now with this sense of urgency you are calling for? Over to you.
Thank you so much for that, and thank you for the opportunity to be on this panel. So, in 2022, at the AIDS 22 conference, we had a satellite session as the Global HIV Prevention Coalition, and we were launching the new roadmap. And I'm really excited because today I'm thinking Dr. Tembi was there, Peter Sands, you were there, and Winnie was there representing UNAIDS. And one of the things that I spoke about or implored, especially Peter and Winnie, was usually when you come to panels, we speak, we strategize, but when we leave, you usually have dementia and you forget. But today, I just want to say thank you, Peter, thank you, Winnie, because you really demonstrated a certain level of leadership. Because right now we're excited. We have the Gender Equality Fund. I think that was a push as the feminist movement, the women movement in HIV prevention, that we need money to move for our work, and we have it, and we're excited. And we're also excited that Winnie held our hand as an African feminist, and we now have the Choice Manifesto that speaks to what we need when we talk about HIV prevention. These are very good efforts, and we are happy. However, I think we should not then forget that we are still in a crisis. Because when we look at what the data is giving us, it doesn't look good. Because I think in 2022 alone, just like what Christine said, the data shows that 3,100 adolescent girls and young women between the ages 15 to 24 were getting infected with HIV every week. And if you break it down, that means like 2 minutes, every 2 minutes, an AGYW is getting infected. And then when we look at children globally, 130,000 infections per year. So that alone, I think, should be something that makes us feel agitated and makes us think about what exactly do we need to be pushing for if we're going to accelerate HIV prevention by 2025. So with the Global Prevention Coalition roadmap, I think it is very clear on the 10-point action plan. And my favorite one is the number 5, which speaks about communities, communities, communities. So when I think about communities and where I come from, I think what we really need to be seeing right now is, firstly, when we talk about adolescent girls and young women, progress has been made. Yes, we're not denying that, but I feel like we can still accelerate, because in the middle of a crisis, there's always an opportunity. And one of the things that I've started to think about is looking at the issues around seeing adolescent girls and young women not only as end users of services, but also as capable human beings that can deliver the services. We best know how to do it. But the challenge comes now when we have the ideas, we don't have the resources to implement. And we even talk about, I know somebody here talked about the issues of research and development and then getting the product to the people. And it has been really very pathetic how it has been happening because we are involved in the researches. They come to our regions, we participate fully, we are into the research, but then the product is ready. It's just not affordable, and that needs to change. Then, when we talk about the communities of HYW, earlier on there was a civil society panel, and one of the people there really spoke about the issues of leadership and how we are looking at creating the new generation of leaders for this HIV movement. And I'll proudly say that I am here because some people have believed and mentored me. And let's not take that for granted. Because believe you me, in 2030, most of you here will be on the other side and will be on this other side. And we're starting to hold each other accountable. But that only works when we're talking about mentorship. I was part of the National AIDS Council board at some point, and I guess I am where I am leading DAWA today because there are people who believed in mentoring me, and there are people who believed in supporting DAWA by providing catalytic funding, which is something that we are not seeing when it comes to new innovations. Because what you do is you really implore communities to be innovative. But when we come with the innovations, we get stuck again because the resources are not there. So we also need then to be, I go back to the fund that I've talked about, because I think one of the most important things that we need to do is to safeguard grant making space for AGYW led organizations, not focused organizations, but led. That becomes very important because what it means is in some way, we are also sort of decolonizing how HIV prevention funding is ongoing. So it means you are really intentionally prioritizing the leadership of adolescent girls and young women. And this can be done from a trust perspective, and we believe it's possible. And as I round off to conclude on this, is I've heard a lot of in this panel the conversation around children, which is really very sad. And one of the things that I am happy about is there's the Global Alliance to End AIDS in Children. And one of the priority population under that alliance is adolescent girls and women who are HIV negative but breastfeeding but at risk of HIV. Whilst we are so happy to have this alliance come forth, what we'll also then see is let's find the intersectionality between the Global Prevention Coalition and this alliance and ensure the pillar we're talking about on HIV prevention is really supported, and there's a key way of us getting together and sharing, knowing that the GPC has already moved some work around prevention, and there's a new alliance. And of course, when we talk of vertical transmission, we're talking about women and girls because they are the mothers. So it's very important that we create that linkage. And finally, I would say the biggest question in the room will always be like, okay, how exactly do you want us to do it? I'll say we have developed a document. We have the HIV Choice Manifesto, and this was developed after so much thoughtful processes and consultation as women in the HIV and AIDS movement, realizing the challenges and the conflicts that we had when CAP LA came, the diprivan ring came, and no one was willing or ready to fund it. So we are also moving on to say, always remember that when you are supporting HIV prevention, it's also about the choice. What does that particular person need? The HIV prevention services that I might need as Nyasha could be different from the next person. So let's not generalize and just say, okay, adolescent girls and young women in Zimbabwe want the female condom, and that's it. What we would want is a basket of choices, and we can be able to protect ourselves, and the prevention agenda can be protected. Thank you.
Thanks a lot. Thanks a lot, Nyasha. I think after listening you, it's difficult to continue to say, well, the youth could really lead, they have be part of the discussion. Thank you. Thank you. It's my pleasure now to introduce Majara Koulibaly, who is the executive director of one of the biggest NGOs in Cote d'Ivoire, called Alliance Cote d'Ivoire. Majara is being engaged with Alliance from decade. She will share with us her amazing experience about how they were able to develop a program for key population in the context of Cote d'Ivoire, which is not easy. And it's really one of those best practice not shared because, again, this connection between Western Central Africa and Eastern Southern Africa we discussed in the last panel, but also the language issue. So, Majara, we are very pleased to have you here. And then the translation is on, I think it was said is on the channel 0 for the English. Or something. Over to you,
Merci,
Majora.
Fodé. Merci aux organisateurs de permettre aux pays francophones d'être présents autour de cette table. Très souvent, dans les réunions au niveau international, surtout quand ça se déroule dans les pays anglophones, les francophones n'ont pas toujours l'espace qu'il faut. Donc, je suis très heureuse de pouvoir partager notre expérience sur le travail que nous faisons avec les populations clés. Donc, je voudrais dire que je suis Dr Oshia Koulibaly Madiara. Je suis la directrice exécutive de l'ONG Alliance Côte d'Ivoire, qui est le récipiendaire principal du Fonds mondial pour le volet communautaire sur la tuberculose et le VIH pendant pratiquement 10 années. Alors, donc, ce qu'il faut dire, c'est que concernant le travail que nous faisons avec les populations clés, tout part d'abord des processus de planification. Donc, assurer l'engagement et la participation des organisations de populations clés dans les processus d'élaboration des plans stratégiques, mais également dans l'élaboration des demandes de financement au PEPFAR et au Fonds mondial, parce que ce sont essentiellement les deux partenaires qui soutiennent la réponse en direction des populations clés dans notre pays. Et c'est quelque chose d'assez important à préserver dans la plupart des pays, parce que c'est le moment où les populations clés peuvent clairement indiquer en matière de prévention leurs besoins, notamment sur les questions de PrEP, pour lesquelles il y a eu beaucoup de discussions avec la partie nationale et qui finalement a été intégrée, les questions d'autotest, la mise à disposition des autotests et comment le rendre disponible au niveau des organisations de populations clés dans le travail. La deuxième chose, c'est que les organisations de populations clés, les populations clés elles-mêmes, sont en première ligne dans la délivrance des services à l'endroit de leurs pairs. D'abord, au niveau des points chauds. Ce sont les pairs éducateurs, HSH, TS, transgenres et usagers de drogue qui donnent l'information à leurs pairs, qui offrent, qui délivrent, qui distribuent les préservatifs, qui distribuent les gels lubrifiants. Nous avons installé des distributeurs automatiques de préservatifs. C'est également eux qui offrent le dépistage. Et avec eux, nous avons travaillé avec les prestataires de santé pour pouvoir créer des structures de santé publique qui sont friendly. Donc, il y a eu des séances de formation sur les questions de stigmatisation et de discrimination dans les structures de santé. Et aujourd'hui, les médecins, les sages-femmes, les infirmiers nous accompagnent pour faire des cliniques de nuit sur les sites prostitutionnels. Donc, en amont, les pères éducateurs font la sensibilisation et les populations clés prennent part aux cliniques, bénéficient donc de consultations sur tous leurs problèmes de santé, sur les questions de santé sexuelle et reproductive, ou même il y a la possibilité de poser des implants, sur les questions de diagnostic et de traitement des IST. Les rendez-vous sont pris dans les structures de santé publique pour pouvoir continuer le travail en offrant la PrEP, en instaurant le traitement antirétroviral pour permettre aux populations clés donc de pouvoir bénéficier de tout le paquet disponible. Nous avons également des dropping centers dédiés, donc qui sont des centres conviviaux dédiés aux populations clés. Et en plus des services déjà évoqués, nous avons des psychologues qui sont mis à disposition et qui offrent, donc qui travaillent sur les questions de santé mentale. Nous avons des pères éducateurs en ligne qui ont des applications mobiles et qui vont en ligne donc contacter d'autres populations clés et leur offrir les services. Et nous sommes très reconnaissants que les subventions que nous mettons en œuvre nous permettent de développer une approche assez compréhensive où les populations clés sont elles-mêmes au devant. Et donc, en plus des prestations de services, le troisième point où nous avons l'engagement des populations clés avec nous, c'est sur les questions de droits humains. Nous travaillons énormément sur la promotion et la protection des droits des populations clés avec des parajuristes qui sont issus des communautés des populations clés et qui sont formés sur les questions juridiques pour pouvoir accompagner leurs pairs et faire le lien avec le système judiciaire et juridique. Nous avons également des formations interactives où les populations clés viennent partager leur vécu avec les prestataires de santé pour aider à changer les perceptions vis-à-vis des populations clés. C'est une approche qu'on appelle l'approche LILO, Looking In, Looking Out, qui fait vraiment la différence. Et nous travaillons également sur les plaidoyers pour pouvoir améliorer l'environnement. Nous avons eu à le faire avec les usagers de drogue pour pouvoir améliorer la loi et faire en sorte que ce ne soit pas seulement le volet répressif qui soit pris en compte, mais également qu'on considère les usagers de drogue comme des malades qui ont besoin de soins. Et cela a été adopté par notre Parlement. Donc, les défis auxquels nous sommes confrontés, c'est vraiment la question de la durabilité des programmes en direction des populations clés. Dans notre pays, en dehors du PEPFAR et du Fonds mondial, qui soutiennent les interventions en direction des populations clés, qui les financent, nous n'avons pas de ressources domestiques qui soutiennent ce type de programme. Et nous savons que le Fonds mondial, dans la contractualisation avec les pays, a ce qu'on appelle le cofinancement, dont les 15 ou 20% qui peuvent être alloués. L'idée, c'est vraiment comment on amène les États progressivement à apprendre à financer ce type d'intervention, peut-être en consacrant sur les 10-15%, 5% ne serait-ce qu'aux interventions communautaires pour soutenir les programmes en direction des populations clés. L'autre question, c'est vraiment comment utiliser l'opportunité de ces financements et de tout l'accompagnement disponible pour créer de la capacité au niveau des organisations de populations clés, donc ce que les anglophones appellent le empowerment. Donc, faire en sorte que ces populations clés sachent gérer des ressources, sachent gérer des financements, sachent faire de la mobilisation de ressources, de sorte à ce que, même en cas de réduction des ressources qui existent, elles puissent être à même de pouvoir aller frapper à d'autres portes pour pouvoir continuer le travail. Et un point assez important, c'est que dans nos pays, il y a beaucoup de discussions sur les travailleurs communautaires, les agents de santé communautaire, avec des politiques, des stratégies de santé communautaire qui sont développées, mais les pères éducateurs, les acteurs communautaires qui travaillent avec la population clé ne sont pas toujours bien intégrés dans ce dispositif. Et pourtant, c'est aussi la voie de la pérennité et de la durabilité de ces programmes. Donc, comment progressivement on peut considérer que ces services délivrés aux populations clés sont des services importants qui ne peuvent pas être délivrés par des ASC classiques, qui ne peuvent pas être délivrés par des prestataires de santé. Nous étions à une réunion où un prestataire de santé nous disait qu'ils ont envoyé un ASC classique dans un fumoir, aller faire le suivi d'un usager de drogue, il a failli être agressé. Donc, ce que nous lui avons dit, c'est qu'évidemment, il faut des pères éducateurs issus de ce domaine, de cette communauté, pour pouvoir délivrer les services à cette communauté. Donc, il y a vraiment la nécessité de voir comment intégrer dans les stratégies nationales de santé communautaire ce type d'acteurs, et tout en évoquant la question de leur indemnisation, de leur protection dans la durabilité. Et enfin, toute la question de la sécurité autour des programmes en direction des populations clés. En Côte d'Ivoire, nous ne sommes pas vraiment inquiétés pour l'instant. Nous avons un cadre qui est plus ou moins favorable, qui nous permet de réaliser des activités, d'offrir des services aux populations clés. Mais nous sommes entourés de plusieurs pays qui sont en crise. Nous sommes entourés aussi de pays où il y a des contraintes liées à la question du travail avec les populations clés. Et dans 2 ans, en 2025, nous aurons les élections présidentielles. Et nous savons aussi que quand les élections présidentielles approchent, c'est le moment où il y a parfois des tensions sur le travail autour des populations clés. Donc pour nous, c'est comment les programmes que nous délivrons en direction des populations clés peuvent contenir des interventions qui assurent la sécurité, non seulement des populations clés, mais des organisations qui implémentent et qui délivrent des services en direction des populations clés. Donc, voici ici résumé ce que nous faisons sur le terrain et les défis auxquels nous sommes confrontés. Merci.
Merci beaucoup, Majara. Thanks a lot. Okay, we reached the end of our panel. It's the time to thank all the panelists again and give the final 30-second words, closing remark to Christine as UNAIDS is hosting the GPC Secretariat. And thanks again, and apologize for the delay of the session.
Thank you. We're playing musical chairs here. I just want to thank the panel. I always feel like when we have discussions where we just hear one person after the other, we miss out on actually asking each other questions and having a proper dialogue. This is not made for that, but hopefully we will improve in having conversations where we can actually have conversations. So I would love to have a conversation with each and every one of you. You have all shared really important lessons and ideas and thoughts. So thank you on behalf of UNAIDS. Thank you on behalf of the joint program, but also in our role as the co-chair of the Global Prevention Coalition, especially thank you to the minister. A couple of things I wanted to say. There is no time to do a big summary, but I thought there were a couple of interesting thoughts. One, obviously, very good to hear both from Zimbabwe and from Cote d'Ivoire about what success can look like and what the ingredients of that success are. I really thought there was an interesting thought about moving from prevention initiatives to prevention systems. And I'm sure that sounds like a nice buzzword, but I do think, you have a big point there that we haven't really created those sustainable prevention systems. Our big problem is, and Madiara talked about it at the end, is the integration of those systems, right? Especially when resources are getting tighter. I think a very clear ask from you, Madiara, to think about how do we make sure we get buy-in from the government to continue funding at prevention services that are addressing the enabling environment, addressing key populations, and making a request for the co-financing for some part of that to be allocated for prevention in particular. We've talked a lot about partnership and how we all need to work differently. And I think as we're thinking more and more about integration and sustainability, we really have to rethink what those partnerships look like and who needs to be part of it, including across government, but obviously including with communities and civil society. And importantly, as you say, Nyasha, including with young people, because especially on this continent, it is young people and young women and adolescent girls and young women in particular who carry the brunt of us failing to prevent new HIV infections. And then maybe the last thought is really about how we are moving on this trajectory about sustainability. And I think we keep on saying things about domestic financing, about integration, about, on one hand, talking about increased choice and increased available access of different methods to different populations, but we are also struggling to make that work at country level when there is reduced resources or as the resources are increasingly being provided by our governments. Peter challenged us to radically rethink prevention, and I really think there is something in there to really think about, is this issue about telling people about risks really making a difference, or is it about healthier choices? And I think, Jorgen, you also talked about that. As we're talking about other health programs, we're talking about healthier choices. We're not warning people just about death and mortality and so forth. So I thought it was an inspiring conversation. I know has been a long day for all of us. So thank you very much for keeping it up. We need to think about how the Global Prevention Coalition is that platform and how do we increase that dialogue between communities, countries, and funders. And so we will continue doing that thinking together with the partners who are supporting the Global Prevention Coalition. So thank you, all of you.